this topic is something that we really think that is important. And this webinar is the second of the series of the organized this time jointly by the European Hemophilia Consortium and European Association of Hemophilia and Allied Disorders. First webinar, maybe some of you did attend couple of months ago. It was organized in a closed format. Only patients with extremely rare bleeding disorders were present. And out of that webinar, we managed to identify few issues and obstacles that patients with extremely rare bleeding disorders are facing today, which we hope to address on this webinar. Some of those issues are quite basic, I would say. That is lack of psychosocial support, then need of recognizing the importance of prevention, need of recognizing the aging population, then lack of education and understanding among the healthcare professionals, and the issue of comprehensive care, meaning that although somewhere formally available, is not always, unfortunately, accessible to patients with extremely rare bleeding disorders. So again, besides sharing personal stories and perspective, we will also try to address these issues throughout this conversation. So we kindly ask you to join the discussion, and to kindly remind you that the second part of the webinar is actually dedicated for the interactive discussion. So we encourage you to join us in our talk. Fee?
Hello. Excellent. Great to see so many familiar and new faces as well, which is really wonderful. And as Stefan has said, you know, this is a joint venture of EHC with in collaboration with EAHAD, which is really exciting, particularly for the rare bleeding disorders community as well, to have that joined up thinking that is often lacking for our rare bleeding disorders as well. So it's really important to shed that light. So I think my job here tonight, and for those of you who don't know Stefan and I, if we have some new people in the audience, or in the room, I should say, Stefan, I will allow you to introduce yourself, but formally in terms of your role at EHC. But my name is Fiona. I have been working with the EHC for many years now, and in the bleeding disorder community for longer than I care to admit, and will show my age. So about 15, 16 years now at this stage, I've lost count, but very much really excited to see that the conversation is finally starting to be more inclusive, more representative of our entire patient with bleeding disorder community as well. So it's a really exciting development for us to be able to facilitate that conversation in a very real way. So Stefan, I'll pass back to you before I introduce to the speakers in the room.
Thanks, Fee. Hello, everyone. Once again, I'm Stefan Radovanovic. I'm patient engagement and community lead in European Hemophilia Consortium. I've been working in this role for the past 6 months, but I've been in the community actively volunteering for the past decade, as I myself have hemophilia A. So I've been quite around. I'm really, as Fiona mentioned, I'm really happy to see that the discussion is going and being more and more intensive when it comes to extremely rare bleeding disorders. As we've come a long way when it comes to hemophilia, we are again now reaching some point when it comes to von Willebrand, but there are so many underserved extremely rare bleeding disorders, and I really hope that the talks and discussions such as this one are big step forward in the treatment and care.
Very well said. Okay, well, it's my pleasure to, number one, invite you all to please, as we go through the speakers, we have 2 patient speakers tonight who are going to share their experience with us and their lived experience and some of the challenges that go with that. And then we're going to have our healthcare professional as well, Saskia, who's going to present with us. So throughout the conversations, please feel free in the chat to add your questions as we go. Obviously, as Stefan said, we're going to have time at the end for that real conversation, but don't hesitate to pop some questions in the chat as we go. So without further ado, I am going to hand over to Christina. So Christina is a patient representative from Austria, but she's currently based in the Netherlands. And then I'll allow her to pass over to Helen. I see you now on my screen. So Helen is also a patient representative from the UK as well. So Christina, I will hand over to you, and thank you both very much for joining us and being willing to share your experience, which is so important in the patient community. So thank you very much.
Thanks, Fiona, and thanks, Stefan, and welcome to everybody. I will start first with basically my history, and then mention some personal experience and challenges that I've experienced over the last 29 years. So I was diagnosed with afibrinogenemia in 1995 when I was born. It was 3 days after I was born due to an umbilical cord bleeding. By then, tests showed that I don't have any kind of measurable fibrinogen, and also my rep delays time as well as the thrombin time is indefinite, so nothing at all. I am the first person to date also in my family to have a bleeding disorder. Nothing was known before I was diagnosed, and it was to many, I think many of you shared this in this call, a big challenge and a big surprise to everybody. And back in 1994-5, that meant also that doctors told my family that I will lead a very restricted life, that I'm basically not allowed to do anything a child is supposed to do. So I then got a helmet, I had elbow protection, and I had knee protection for the first 3 years in my life. And we were told that any kind of trauma, after any kind of trauma, we should go to the hospital, which resulted in us going 64 times a year to the hospital, which was another challenge. But yeah, so by then my parents said, okay, no, this will definitely not be the future. So we did some research, or they did some research, and they found hospitals in Germany and in Switzerland, which is nice because it's the same language, and my parents were not as good in English as we are today, I think. And then we found treatment centers who had experience, and they said that treatment is better than non-treatment, which is why they convinced my doctors to have prophylaxis from then on, which also meant that I didn't have to wear a helmet anymore and anything else. So from then on, given also growth and weight gain, I increased my dosage, of course, but now I currently receive medication, or I give it to myself, which is also more than half my life by now. So since I was 14, I infuse twice a week. I mean, I now infuse twice a week, but I infuse twice a week with Fibriga, which also changed after my move to the Netherlands. And this is due also to have like a level of 100, which is, I think maybe Dr. Schols mentions, at least for afibrinogenemia patients, a perfect actually result to have, because that also means that I could undergo any kind of emergency treatment or whatsoever. So that is the goal, and this is where I'm now. And of course, I had some bleedings before, and yeah, but now didn't have any bleedings other than the bruises that I have when I bump into things, because I'm a bit clumsy. But I feel very good, and I travel a lot. I've traveled 3 months to South America. I brought an extra suitcase for my medicine. I currently just came back from holidays, so I feel like this is more of a side effect than actually a big backpack to carry around. But yeah, coming to the biggest challenges, I think that's also a bit personal to me, but I think maybe it's also good guidance for people who think about they want to living somewhere else. For me, it was moving in Europe because my boyfriend is Dutch, and I wanted to live with him in the Netherlands. But at first, I was like, I can't, because everybody who has a rare disease know how difficult it is to get the treatment you need, to have access to doctors that know your story whatsoever. So what I did is, I think 2 years before I decided to move, I contacted my doctor in Vienna and said, this is what I want to do. And I want to have everything prepared that's possible to be able to move. So we also did some genetic testing. I now know that I have 2 mutations. We documented everything that was there to document. And I think maybe the doctors in Amsterdam, I mean, they were happy with what they got provided. I think they got more than they needed, but at least I knew that everything was prepared for when I wanted to move. So fast forward last October, I think December was the time I went to the hospital. I was told that I could continue with what I had before, and also now feel very well treated. Also given, I think, the great cooperation in the Netherlands between the doctors there, because my doctor also cooperated with Dr. Schols, I think, on some studies, so that is quite good. And another one, which brings me to the cooperation of doctors, and I think which is also mentioned before, I think I was in more than one life-threatening situations because doctors did not cooperate and also had limited knowledge, but still tried to treat me, which so I was once preparing my own medication, which was put on my lap before an operation, because the nurse said she's not allowed to mix it. I knew that it took some time to mix, and in the end it was injected instead of giving an infusion. So it was not the best opportunity. But what I also learned is this cooperation or the knowledge or whatever is also definitely related to the rare condition that I have, or that we all have and share. It's also due to the lack of representation, because as Steph mentioned, hemophilia and von Willebrand are very much mentioned in every sentence. Bleeding disorders are mentioned in every catalog for insurances or whatsoever. But once you mention you have something else, either they think you have hemophilia, then you say you're a girl, you can't have hemophilia, or they're like, you have anemia, which was something totally different, and give you something else, which is not good. But yeah, in the end, I think what we really need is more research and more representation and more cooperation, because also, for example, as I mentioned, I think Dr. Schols' research in 2021, I think, or 2020, on two patients in Nijmegen who were pregnant, also was like to my mom, you know, this is the study. There are two people in Europe who gave birth. I will move there and I can give birth as well, which is, I mean, for aneuploidy patients is a big issue as well. So that reading things and knowing that there are studies helps patients as much as they help healthcare providers, I think, as well. And I also think is what I've also seen in the past is you should also push your doctors to cooperate, because in the end, my parents were the ones basically handing the telephone to the doctor saying, there's somebody who has knowledge. You don't have to guess. You don't have to say, I think this is like that. So rather calling them and really speaking about it is also what you should do. And I think at least in Austria, it was the case for me that I was the first patient in my hospital with my disease, and they really didn't know it existed until they by chance found another doctor who has ever heard about it. So I think that's also really important. Another one, and I think that's also mentioned a bit before by me now, is be your own biggest advocate. If you don't speak for yourself, nobody will speak, and nobody knows as much as you do about your disease as you do yourself. And I mean, I hope this is the case for everybody, because without that, you're a bit lost. And because, as I said before, it's rare. And I've learned in a lot of occasions, don't expect people to know what you have. And I don't know how often I've heard, you won a gene lottery. Like, it's nice to be told that you won the lottery. You don't want to win gene lottery, because most of the times it's not a lottery that should be won by anybody. But that's what I'm doing. Like I've been doing this, like speaking at events and taking part in Facebook groups and whatsoever for the last, I think, 10 years, because at first I was really annoyed, sorry, Stefan, with hemophilia patients, because there was somebody around every event and there was a lot of knowledge and talk about it. And I was like, yeah, but I don't feel represented. Why should I take part? But that's in the end, the reason you should take part is because through that you meet other people, and then you have meetings like this where people with rare diseases or really rare bleeding disorders talk together. And I think that's also what healthcare providers are doing now. Like, I know there are a lot of people working on afibrinogenemia right now, and also factor 1 deficiencies, and that's definitely more than there was the last for the last 30 years that I've been alive. And I think we can only all benefit from it, because all of the clotting factors, they're so related, and if one doesn't work, others that don't work. So I think putting it in the spotlight and fighting for yourself, and even though you think you're annoying, and I once, sorry, and then with that I will close. I have to admit, I once went with the studies, I think I had 3 studies, to a doctor who was like the head of the department. And she was like, why should I look at that? And I know it was like, you don't need to look at it, but I know colleagues, if you haven't looked at it and they misdiagnosed me or they mistreated me, and I just want to know from my side that I did everything that I could to provide you with that. And if you throw it in the bin, throw it in the bin, but at least I did it. So even if it feels weird, if you think you may overstep because you tell somebody who has knowledge about the thing, do it, because if you don't do it, there might be more question marks after you talk than before. And yeah, that's where I am today. I'm actually very happy with my situation, and always here to help anybody who has any questions about self-infusing, treating yourself, moving countries, because that's very scary when you're told they infuse differently, they use different medicines, and you're like, but I was told this is not possible. So yeah, always here to help and answer questions. And with that, I hand back to you guys.
Thank you so much, Christina. What a journey from 64 visits to the hospital to 3 months of travel. Very large suitcases, I imagine, for treatment. But, I think thematically you've hit on something that resonates with every person in this room with a rare bleeding disorder, in terms of those challenges, those fears. And really, I suppose, finding that clinician that can really transform your care and your experience as well, when there is that knowledge and that willingness as well. So thank you very much. I'm sure there will be a lot of questions in there for you at the end. But with that, I will hand over to Helen. So Helen is our patient representative from the UK. Good to see you again.
Hi, everyone. Thank you, Christina. Actually, that's given me a lot to think about as well. And thanks everyone for joining us. So I have factor V deficiency. I'm also actually a dance teacher and a trustee of the UK Haemophilia Society. So factor V deficiency affects about 1 in a million, it's estimated. But again, sometimes I think lack of research, who is sure. So my body obviously doesn't produce enough factor V protein. Symptoms I've experienced is excessive bruising, excessive traumatic bleeding, joint and muscle bleeds, heavy menstrual bleeding, ovulation bleeding. I've even had bleeding into a bone. And I would say this has really kind of affected my entire life. I was diagnosed at birth with an intracranial bleed. So I think I have kind of a long experience of moving from kind of childhood experience into adult care. And I think the longer I've lived, the more scary it's kind of become. I think when you're a child, you trust your parents and you trust everybody that you meet, including medical professionals, and you think, oh, they know exactly what they're doing. And actually, the longer the more I've experienced and the longer I've lived, I've thought, oh, actually, really, no, they don't. There's a real lack of research in, I would say, all of the rarer deficiencies. And I think that's an issue that it's really good now that it's starting to get highlighted everywhere. For factor V deficiency, there is no factor concentrate available. So my treatment for a minor bleed is tranexamic acid, but for either kind of pre-surgery or a bigger bleed would be FFP. So that has its own kind of challenges, because I think especially when Christina was talking about traveling and things, like I do travel, but I would say it's very scary because you're relying on someone at the other end. If something was to happen, there is no prophylaxis, there is no way to treat yourself in advance. Kind of touching on like my childhood growing up, I would say I felt really different from peers, and I think that really wasn't addressed. I would say years ago, it's kind of, you have a bleed, you go to the hospital, you deal with it. But there was a lot of things that, you know, you can't do this, you can't do that. I mean, I danced anyway, but it ended up in the hospital a lot. But I think that's something I've really taken with me. And I think that's the reason I actually chose to become a dance teacher, just to prove everybody wrong that I could do it. And I have. It comes with its own challenges, but yeah, I did. The main thing I actually kind of want to touch on is then if you are diagnosed at birth, is then when you move into kind of adult care, nobody ever really sat me down and talked me through it. And it's only really recently when I've met other people in a similar situation to myself that I actually realized how vulnerable I was. I think you get very scared that when you go to the emergency room that they're not going to understand, and that, like, what power do you have to kind of challenge these things? Like, especially when you're very rare, I would say I know my body, but there's a lot of pushback, especially from professionals that aren't really aware of what's going on. And there isn't actually a lot of research out there, even for them, to kind of know what to do with you. So really, I think things like this, it's really good for everyone to speak, but also to learn how to advocate for themselves. That is something I've been working on with some friends really recently. Kind of a recent experience. I had a lot of heavy menstrual bleeding due to a polyp. And when I went to the hospital, it was kind of the attitude of, well, you're not going to die right now, so you don't really need any treatment. And I was like, but it will continue to bleed, so then it will become a problem. So with help from a very good friend, I kind of learned what to say. So actually a suggestion that I would have from this kind of meeting is to kind of hold more advocacy courses and how to speak in the hospital. I would say I don't have a lot of knowledge. I'm not medically trained. And how to really approach that conversation with like your medical professionals, your medical team, knowing what services are out there and what you should be entitled to, and also how to kind of discuss kind of shared decision making and understanding like the risks and the benefit of different treatments, and how to discuss that maturely with your doctor. Because I really think that had I known, like had I really thought about this a few years ago, I would have felt a lot safer. I think that we've been touching on this idea of a lack of like mental health support and psychosocial care. And that's actually a massive issue in my life. I think I felt really, really unsafe to do a lot of things. I'm a person who will not walk down the stairs without holding on to things just to make sure that I don't end up in that position where I'm kind of fighting to be heard. So I kind of think the point I'm trying to make is that I really want to advocate for a healthcare system to like that listens and responds to the needs of people with rare disorders, and equally to like increase awareness of rare conditions, and this kind of idea and a practice that if someone does have a rare condition, they are kind of part of the discussion, they are part of the expert team, and they should be consulted when we make in treatment plans, as well as more access to mental health support, or like physio support and things like that. I would say it's, well, not that I was shunned, but I've been steered away from having the full service quite a lot of times because it's, oh, you have factor 5, it can't possibly affect you that way. But realistically, what the truth is that you only go to the hospital if you think it is life-threatening, because like a transfusion is a massive decision. It's got a lot of risks to it. So you would only actually get that if there is a risk of death, which sounds dramatic. So when they talk about your bleed rate, it probably doesn't look that much on paper, but actually in real life, a lot has happened. But yeah, I feel like that's me. Feel free to ask me any questions. I'm probably better in a question situation.
Thank you so much, Helen. I think again, just like Christina, you've touched on some really important points, like trust and safety are the two things that are really in my mind, because that is what makes and transforms a patient's life if they feel that safety and that trust with their treatment and their care. But also, I think you've started to touch on the broader elements as well of the patient as a whole, and not just looking at the patient in terms of a specific treatment or finding something to treat a bleed, whether it's a specific treatment or not, but it's that mental health element, it's that physiotherapy element, it's that access to whole services that's really, really important. So thank you for sharing your story. Always, again, as Stefan and I have said so many times, every time we have these conversations, I'm not a patient, Stefan is, but you learn something so invaluable and so rich, that we can really, move forward and make sure that that conversation is brought to the community. So Stefan, I will hand over to you to introduce Saskia, and really looking forward to the Q&A.
I want to thank first Helen and Christina both for sharing their personal stories. It's really impactful. I would like to introduce now Saskia Schols. She's an internist-haematologist from the University Medical Center of Radboud, UMC in the Netherlands. Her work is focused on BDUC and rare bleeding disorders in general, and we truly believe that her insight and knowledge is invaluable for our conversation. So please, Saskia.
Thank you very much for the nice introduction, and thank you very much for the invitation. I've prepared a presentation and I would like to share it with you. So I think, I think you all can see my presentation on screen. I cannot see you all, but please speak up if you have any questions during the presentation. I would like to give you a clinical overview of very rare coagulation factor deficiencies. From the European Network of Rare Bleeding Disorders, we have learned that factor 7 and factor 11 are amongst the most prevalent rare bleeding disorders. And in contrast to factor 2 and the combined factor 5 and factor 8 are among the rarest rare bleeding disorder. But how rare is rare? We've heard from Christina a estimated prevalence of 1 in 2 million. And on the right, you can see the table of the estimated prevalence of B allelic affected patients. So these are patients with either a homozygous genotype or compound heterozygous genotype. And you can see it ranges from 1 in 500,000 for factor 7 to 1 in 2 million for factor 13. But however, mild factor deficiency are much more prevalent than these estimated prevalences. And to assess the bleeding phenotype of patients with rare bleeding disorders, a clinical bleeding severity grade was introduced by Flora Paivandi in 2012. And it ranges from asymptomatic patients to grade 1, grade 2, or grade 3 bleeding. And grade 3 bleeding corresponds to major spontaneous bleeding, so the intracranial bleeding, which was already mentioned. And to the right, you can see that there is a large heterogeneity in a single rare bleeding disorder, but also between the different rare bleeding disorder. And this is data from the European Network of Rare Bleeding Disorders. And as you can see, grade 3 bleeding is most prevalent in fibrinogen, factor 10 and factor 13 deficiency, but it all depends on the inclusion of patients with a severe factor deficiency. So there is some selection bias here. In the second part of my talk, I would like to present you results of our nationwide RBIN study. It's a cross-sectional study which was conducted in 2017 to 2019. And we included adults and children from 1 year on. And every hemophilia treatment center of the Netherlands participated. We have 6 hemophilia treatment centers divided in 9 locations. You can see it on the right in the map. And all patients were included who had actually a factor deficiency, so lower than the lower limit of normal, or a pathogenic genetic variant of at least class 3. And all the patients who participated in this ARBIN study were already registered in a hemophilia treatment center. So there is some selection bias in our study. And both patients with a severe factor deficiency, but also with mild factor deficiencies, were included. So in total, we included 263 patients. There were 205 adults, and the majority were female, 131. And we also included 58 children. And of all these included patients, 21 patients were on chronic long-term prophylactic therapy. And on the right, you can see all the different rare bleeding disorders. And factor 7 fibrinogen deficiencies and factor 11 were amongst the most prevalent. And this is just comparable to the European Network of Rare Bleeding Disorders study, which was performed previously. So in this figure, you can see that we included patients with severe factor deficiencies. On the y-axis, you see the factor activity, the baseline factor activity level. But of course, we also included patients with mild factor deficiencies and even family members who had normal factor activity levels but harbored the specific genetic variant. And so for all the patients, we assessed the bleeding phenotype by determining the ISTH-BUT score. And on the x-axis, you can see the 14 items of this ISTH bleeding assessment tool. All the different colors correspond to the specific rare bleeding disorder. But overall, in general, we saw that patients with a rare bleeding disorder, very rare coagulation factor deficiencies, almost always bleed after tooth extraction, post-surgery. Women had heavy menstrual bleeding, and there were a lot of women with rare bleeding disorders who had a postpartum hemorrhage. And so we also analyzed the baseline factor activity level in association with the bleeding phenotype determined by the ISTH-BUT score, but also by the bleeding severity. And the ISTH-BUT score and bleeding severity corresponded very close to each other. But if you see the correlation for fibrinogen, factor 2, factor 5, and factor 10, there is quite a moderate correlation between the baseline factor activity level and the ISTH-BUT score. And however, in panel F, you can see for factor 11 deficiency, there is no correlation at all between the baseline factor 11 level and the ISTH-BUT score. And in general, for hemophilia, we know that there is quite a good correlation between the factor 8 activity and the bleeding phenotype. But in patients with very rare coagulation factor deficiencies, this correlation is not so strong as we thought it was. So we also assessed the bleeding severity. And for the patient in our population, the majority had grade 2 and grade 3 bleeding. So major bleeding or spontaneous bleeding, major bleeding after surgery or spontaneous bleeding. So this represents a population with a very severe bleeding phenotype. We also performed a whole exome sequencing genotype assessing in 156 patients. We have a panel of 156 genes, all corresponding to a thrombotic or a hemostatic disorder. And of 103 patients, we found a genetic variant in the corresponding rare bleeding disorder gene. And in 38 patients, we found a variant in more than 2 rare bleeding disorders genes. So patients with more than 2 factor activity deficiencies. And for 15 patients with a mild bleeding, mild factor deficiency, we didn't find any genetic variant. Then we analyzed patients with a B allelic genotype. 43 patients were homozygously affected or compound heterozygous affected. And on the left, you can see this patient group. The majority had grade 3 bleeding or grade 2 bleeding. So really representing a severe bleeding phenotype. And on the right, you can see 70 patients with a monoallelic affected genotype. and the majority had at least grade 2 bleeding. So mild factor deficiency is not asymptomatic. Patients really have a bleeding tendency. And then we assessed retrospectively the invasive procedures, and we split the group in patients with a B allelic affected genotype on the left, and on the right patients with a heterozygous genotype. In group 1, patients with a B allelic affected genotype, 103 invasive procedures were performed. In patients with prophylactic hemostatic therapy, either tranexamic acid or factor concentrate or plasma, a few patients had a bleeding complication. It was more or less comparable group 1 with group 2. And as you can see, for patients without any prophylactic hemostatic therapy, there was a significant number of patients from group 1 and group 2 which bleed after and during the procedure. So this is very important information, that not only patients who are severely affected, but also patients with a mildly factor deficiency can bleed during invasive procedures. So we also analyzed a subgroup of patients in our ARBIN population for gender-specific bleeding problems. And we saw for women with a very rare coagulation factor deficiency that nearly 70 to almost 100% of women with a very rare coagulation factor deficiency had heavy menstrual bleeding. And the therapy to treat this heavy menstrual bleeding, in the majority of the women, they had iron suppletion in the past, hormonal therapy of tranexamic acid, but to the right, for women which had a ISH-BOD score for this item at least 4, there were a significant number who underwent an endometrial ablation or dilatation and curettage or hysterectomy. And in my last, one of my last slides, I would like to focus on the age of diagnosis of women with a very rare coagulation factor deficiency. We saw that 76% had menstrual bleeding from the first menstrual period, so since menarche. But the average age at diagnosis of a rare bleeding disorder is 28 years. And this really shows the diagnostic delay, which is still present for our patients. So I would like to summarize the messages from my presentation. Rare bleeding disorders most often have a bleeding phenotype in which there is bleeding complicated after trauma, after invasive procedure, and there are women-specific bleeding, such as postpartum hemorrhage and heavy menstrual bleeding. In these very rare coagulation factor deficiencies, there's no clear correlation between the baseline factor activity level and the corresponding bleeding phenotype. And the majority of patients with a very rare coagulation factor deficiency have a corresponding monogenetic affected gene. We saw that for the future, improved perioperative care is needed, not only for patients who are severely affected, but also patients with a mild factor deficiency. And specific for women, earlier detection of a rare bleeding disorder is very important to reduce the burden of heavy menstrual bleeding. And I would like to answer questions, and I will share my screen. Yeah, I think we're back to the audience.
Thank you, Saskia, for showing the results of your study. It's really important to see that, especially that the phenotype, bleeding phenotype, is not necessarily matching always the baseline factor activity. I wanted to ask if there are any questions from the crowd. I do have a few, but I would like to give to you guys if you have some questions. Yes, Olivia?
Yes, good evening, everyone. Evening for those who, or it's evening. I'm lost here. Thank you for the 3 nice interventions and presentations. I am the CEO of the EHC, and I have a daughter with severe hemophilia A, so I know what it feels to be a minority in the minority. And she went to the ER this week, I mean last weekend. So I know what it is to show up and not being believed. So I was wondering on that note, how the HC can help educate and help patients be more assertive or handle the emergency room better, and probably the physicians too, because of course we have Saskia here, very knowledgeable, and she knows that you can have a factor deficiency that is super rare. You can be a woman with heavy menstrual bleed or ovarian bleeds, and you have to be treated in a very specific way. So it's very easy. If you show up at the ER, it's Saskia on duty, easy. But it's not always the case, I can tell you. Friday I had to teach another lesson at the ER. So how can the EHC help you in getting that education that helps you handle things at the ER?
Olivia, just to be sure that it is there is awareness, we hand over all our patients with an emergency card, stressing out their specific coagulation disorder, and also give our phone number, and we're 24 hours a day we are available for assistance. I know that even when patients hand over this emergency card or maybe a general treatment plan, there are a lot of physicians who will throw it away or don't believe it, and that's a very important sign or vicious circle that we have to break through. I think general giving these webinars and giving educational sessions in a hospital is so important to make these physicians aware of the bleeding complications. And it's not easy, but I think it will take years and years. Before we didn't give our carriers of hemophilia much attention, but now after so many years, finally people becoming aware that women with hemophilia do exist and do bleed. So repeating that very rare coagulation factor deficiencies can result in bleeding, I think that is the most important thing.
Yes, Christina.
From a personal perspective, and this may work better in smaller hospitals or for children, we encountered many of those ER visits where people just had more question marks than, like, after you stopped talking than before. In the end, we had a poster, an A4 poster with my name, with my doctor and the number, and saying that if this person, it was behind the wall, so I didn't have access, but I know it was hanging there. So if this person shows up or is part of this treatment center, of the hemophilia treatment center, then this number should be called. Also, my hospital in Vienna and both in Amsterdam, they have this number, this 24/7 number where you can call. So even if they're not in the ER downstairs, they can send somebody or talk to somebody, because it's always, I think, better talking from physician to physician, at least when they think you don't know a lot. So I think, and then again, I think it's also maybe the EHC can talk to more healthcare providers on, like, information material, and also I think this is more, I don't have knowledge on that, but maybe Saskia has, like, internal, like, meetings in the hospitals to put this on a bigger, like, agenda, and to talk about that also people with hemophilia, like women with hemophilia or whatever, any other rare disease can show up. And if they show up and say that, then it's really important to call these numbers, because I experienced that even if people talk to each other between different departments, in the end, it can also happen that they think that there is no time, and then that can be exactly that moment where there needs to be time, where there needs to be infusion. So I think it's both patients talking to doctors, having signs or whatever, but also maybe you guys can think of ways on how to create presentations or more knowledge, and also within hospitals to have those kind of workshops in regular meetings or whatever, where you can put the focus on.
Helen?
Just in kind of an idea on how the EHC could really help. Something that's really helped me that a friend did is actually kind of created a bit of a toolkit on kind of language to use. So if you do find yourself against a healthcare professional that isn't necessarily sure, they also need to be able to trust you, and they need to trust that you know what you're talking about. So like a toolkit of kind of language to use, and things to say, like how to address that issue. If that would make sense, that's something that the EHC could do if they were kind of
That's very important. Having the lexicon of the healthcare provider who is in front of you helps, because they sometimes when you use just the right lexicon, they really trust you and they take you seriously. And like, are you a doctor? No, I'm not a doctor, but I know my condition. So yeah, definitely that's a good idea. Thank you, Helen.
And on our website of our hemophilia treatment center from the Radboud, we have for every very rare coagulation factor deficiency a specific movie, a sort information movie made from our students as a sort of assignment. And it is made very easy. It is like a dummy video for everybody, for family members, but also for physicians who do not really know the disorder, how to recognize bleeding and how to treat them. And I think if you can post such easy videos, then you can also refer to them, because it's made very, very clear how it works, the bleeding disorders.
Yeah, we have a question from the audience, Nikki van Ginnick, and she asked, how can we educate medical teams who don't often work with patients with rare bleeding disorders, mostly non-hematology department? Mostly they don't even haven't even heard about it, and this belief is all around the corner. She said, my medical team is in the hospital nearby, won't help me with a bleeding problem, but my hematology department is around 1.5 hours away, hour and a half away. What is the best advice for this?
Yeah, Nikki, the best thing to do in the Netherlands, we are very good organized. In the Radboud, we have a lot of collaboration with our hospitals around our neighborhood. And we're educating them each year, educating them about our problems. Because often we have to assist a invasive procedure in the specific hospital, which cannot take place in the Radboud. And I think what was very important, that you inform the hematological department of that specific hospital, and you really stress out that they had to take contact with your hemophilia treatment center. And in the Netherlands, we're very, very much fond of our collaboration. So if you have the feeling that you will not be heard, please say that your hematologist has to contact the hemophilia treatment center of the Radboud. Yeah, that's very important.
Yeah, as Chris said, don't be afraid to phone your center yourself if the medics at ER won't listen to you.
Yeah, very, very good advice. Yeah.
Yeah. Yes, Christina, when you mentioned that you won the gene lottery, right? But again, in those unfortunate circumstances, you were quite lucky, I would say. You know, you had luck to live in an area where that is quite recognized, and now you have Dr. Saskia Schols that is taking care of you. But again, it's something that we need definitely to address and to improve the visibility of people with rare bleeding disorders, because again, not everyone can be in a situation to have an expert on the opposite side or next to them. So again, this is something that we definitely need to address. And again, this is joint webinar of the AT and EAHAD. So again, this is one of hopefully many steps that we will jointly take to overcome these barriers. Jim raised his hand, but Christina, is this a reply to this? So
Yeah,
maybe...
just I know that I'm lucky to have been born in Europe and whatever, but I think 99% of my outcome is the result of my mom's work. And without parents who are not engaged or who think, okay, this is how we have to live, this would not be possible. So I think it's not only for the patients, and I guess I can speak of for Helen and Olivia as well. It's quite a thing to have a bleeding disorder in the family. My mom thought she was responsible for that because she had thrombosis in the past and she had to do blood clot, like she had to take blood thinners during the pregnancy. So I think it's really, really important to already start with the parents to be active and to be an advocate for the people when they can't speak for themselves. But that's just a shout out to my mom.
Jim?
Thanks, Stefan. The communication issue, I think, is very important, and it's critical that people can get the message across. And I know I've recently experienced a hospital where I had never attended before in an ER situation. But in Ireland, we have our severe bleeding disorder card, which we carry. And I gave it to the doctor when I was admitted, and I asked them to contact our comprehensive care centre, which they did eventually after about 2 hours. And they spoke with the hematologist on call. But I could hear the guy, he was standing next to me, and he was telling the hematologist that he had a factor 9 patient. I'm actually factor 8. And that I use a factor replacement product. I don't. I have inhibitors, so I use a bypass product. So I was correcting him verbally as he was telling the hematologist who he had with him. So about 10 minutes later, I got a phone call on my mobile from the hematologist. He said, I could hear you in the background. And he said, I could tell you knew more than he did. So he said, I want you to do this, etc. So we got a conversation going, and eventually I got sorted out. But it is important, and I think this is very essential to have a card like this. The NMO in Ireland prepared this in conjunction with the Comprehensive Care Centre. So we distribute them to our members, and everybody with a rare bleeding disorder carries one in Ireland if they're registered at a centre.
Yeah, that is again, unfortunately, something that's a lot of countries still don't have. It's something that looks quite simple, but it's quite effective. It's important that the physicians do understand what that card means and how to react and respond when they see it. I wanted to ask again, going back to Christina's and Helen's talk, but the question is for Saskia. As you mentioned, the importance, of course, of the adequate therapy, and Christina, you said that although again you were facing challenges, you have an adequate therapy that basically at the moment is effective for your disorder. But for instance, factor 5 doesn't have, patients with factor 5 deficiency do not have adequate therapy, which unfortunately Helen has. So my question to Dr. Saskia would be, what would be the solution? Because again, there were mentions of basket trials for basically trying to find a medicine for similar disorders that can be used for them, because again we don't have, again we are talking about numbers, not only about finances, but also the number of patients, as we don't have enough number of people with certain disorders. Is it possible to somehow to continue a talk in that direction in using basket trials, maybe even in even greater capacity, and again to go to a moment where we do have treatment, and adequate actually treatment for extremely rare bleeding disorders.
Yeah, that's a very good point, and especially factor 5, in which we don't have any exact concentrate like we have in factor 13, fibrinogen. It's very important that there must be some way accessed in trials for, I think, the rebalancing agents, because these agents are so good for patients with a very rare coagulation factor deficiency, especially the severe ones, which sometimes need long-term prophylactic therapy. Especially women which face heavy menstrual bleeding every month with a very low factor 5, they can be treated with long-term rebalancing agents. So yeah, I think, and I hear the voices of these patients to are very willing to participate in these trials. So I think that will be the future. Yeah, and now that we are raising more awareness for even mild factor deficiencies, I think the voices will be heard to the pharmaceutical companies to include not only patients with hemophilia, but also patients with a very rare coagulation factor deficiencies for these very broad indicated rebalancing agents. Yeah.
Chris, I saw that you raised your hand. I don't know if you...
My biggest problem, even though I'm very proactive and very gobby, I am still having real problems getting my doctors to refer me to the hospital where my treatment centre is, even though they've got loads of letters. It's as if the computer says, no, we can't refer you to there. It's all got to be done electronically. The hospital won't accept emails or paper copies of referrals. It's, you know, it seems to be, and the more digitally, electronically advanced we're getting, the more difficult it seems to be able to do referrals out of area. And I don't know if the doctor's got any advice.
And what kind of referral do you mean? Do you mean a referral to a regional hospital for a specific department?
My local hospital, I've got
Yeah.
it's a dermatology appointment. I've been to my local hospital. They said they can't do anything else because of my blood. They referred me back to my doctors. My doctors have been trying to refer me now since January, but the referral keeps bouncing back. And in the end, I've phoned up, I've spoke to one of my hematology consultants, and they have sorted it, but it's just a ridiculous process to do that.
Yeah. Yeah, I recognize it, especially by my patients who had to undergo a dental extraction, that there are a lot of dentists who are very afraid of doing things on patients with a bleeding tendency. But sometimes it helps that the referral is in a comprehensive care center. And that's sometimes it's the only way to have a specialist other than a hematologist for a specific problem to refer to. It's a real problem, I understand, but sometimes you have to be referred in your own hemophilia treatment center.
But I'm trying, yeah, because I'm trying to get referred to my haemophilia centre.
Yeah,
I live out of area. That's my problem. It's
yeah,
it's
it's
out
a long
of area.
distance. Yeah, I understand, but sometimes that's better to travel to a very good comprehensive center than in a local hospital, which they do not really know what's going on when they are treating you.
I know it's just getting my comprehensive care centre to accept my referrals. That's my problem.
Yeah.
Yeah.
Okay, understand. Difficult. Yeah.
Yeah.
There is
Thank you.
Thank you, Chris. There is a comment from Audrey Jensen. My 14-month old daughter, Jane, has afibrinogenemia. We live in New York City. Our hematologist gave us a letter that explains her diagnosis, treatment, and their contact information that we carry on us whenever we travel. We also are told the closest treatment center, pediatric hospital to go to if there is an emergency if we are outside of New York City. But honestly, we don't expect most doctors to know her disorder. And my husband and I are her advocates and are learning to push back to doctors who try to treat her wrong. In the end of the day, it always comes to that again, to that individual advocacy. And again, going back to Christina, as you mentioned, your mom was your advocate for you, and now you are your own best advocate. I wanted to ask both Christina and Helen, besides that individual advocacy efforts that you have, do you think that the NMO or your national society can do something to help you in sharing awareness about the extremely rare bleeding disorders? As you mentioned, Christina, that you felt isolated even within the bleeding disorder community. People with hemophilia do feel isolated outside potentially, but again, within the bleeding disorder, almost everyone around them have the same disorder. But again, when it comes to extremely rare bleeding disorders, you feel isolated even in your own community. So what do you think should be and could be done? Both, it's a question for both Christina and Helen. What do you think could and should be done on the national and the international level?
Shall I start? So on a national level, I would say we're very lucky to have an Amy who is watching, who has massively pushed the cause of rares and BDUC in the UK. And actually now we have kind of a rares working group. And we're working towards kind of having an event for everyone, hopefully, fingers crossed, we're hoping to work towards this, where people can meet each other and share experiences. I would say I came to the ERIN summit last year, and actually that's made a massive difference. I think before that, as a person with a rare bleeding disorder, felt very, very isolating. Our national NMO really, it just didn't feel like it was for me at all. I was a member for 30 years and didn't engage at all. So I do think that we're starting to make progress, but I would say that we're the ones that are making the process. So it's just about encouraging more people to join in and join the conversation, and kind of on a national level and an international level.
I think in the end, it's about representation and giving more space to those diseases. I mean, it's the same. We talk about women on boards, and I know that there are different views about, do we need it, do we want it, is it good or whatever. But I think rare bleeding disorders, at least in my former or my national member organization, is desperately underrepresented. And if we're talking about anything else than hemophilia in there, it's women who are carriers most of the times, and not really those rare bleeding disorders, which is, for example, factor 7. I know that there are some patients in Austria, or my disease. And I mean, Austria is also quite small. We only have 8 million people. So, but I think is giving room to those is really important. For example, it's representation on the website. When you look on some national member organizations, they list the bleeding disorders and they don't list anything else than Van or hemophilia. For starting with that, just for people like me to go there to see, for example, what Radboud or hospital does, like having these dummy interviews. Like there are resources from the World Federation, I guess also as well from the Hemophilia Consortium in Europe, to just put there and to share you guys, you're also there. It's not just the ones that are listed. And then also in meetings, in summer camps, in member meetings or whatever. Like I once went to one because I had high hopes because there was a mention of rare, but whatever rare I thought I was represented, and I was there. And in the end, there was it was about new treatment options and whatsoever. And I knew that there was, for example, Fibroga coming up, which is a new product, because before there was only one for factor 1 deficiencies. And there was nothing at all talked about that. And I think it's really representation. And even for, it's just this quota. I don't know, give 1% per year more to that. And in the end, I mean, it takes 100 years, but in the end, there's 100% more representation. But if we don't talk about it in national members organization, people like me won't show up. People like me don't feel like they are represented. There's anybody there who has knowledge. So I think in the end, it's really it's really an opportunity and also a necessity to give more space to those rare diseases, because I think we've reached a level where there's really good treatment options for hemophilia, there's really good treatment options for von Willebrand, there's gene therapy, whatsoever. I think this is now the time to give a bit more space to those underrepresented bleeding disorders. And not to bash anything, but I haven't seen that in my national member organization. And I think if that was that, a lot of other people would be showing up more, or at least feel more represented. In the end, that's what matters, not only physically, but also mentally.
Yeah, absolutely. Absolutely. Sometimes it's a patient with extremely rare bleeding disorder is only one per society, and it can be really challenging for that someone. And that shows that actually maybe the approach of the advocating for extremely rare might be slightly different than when it comes to hemophilia or von Willebrand or the disorders that are higher in numbers, because again, on the national levels, sometimes those numbers are just not enough. And then we should probably or think about reorganizing and again advocating on the international or regional level in order to have a stronger voice when it comes to extremely rare bleeding disorders. So yeah, I understand absolutely, Christina. So Saskia, I wanted to ask you, we discussed about again the potential of the basket trials for the availability of the therapy, and I wanted to ask you what could be done or should be done in the ideal world to improve the diagnosis, as you mentioned again in your study results that although patients with mild deficiency can bleed when having procedures or some trauma. So I believe that it's quite known in our community, but not so much in the wider public, that it should be that the diagnosis is actually quite important even with the mild symptoms.
Yeah, and it's very good to educate physicians that even with normal bleeding times and normal pro-trauma time and APTT, still there can be a mild factor deficiency. And based on that, we have revised our Dutch national guideline that for a patient with a bleeding tendency without a deficiency in factor 8 or von Willebrand, with normal PT and APT, the next step to be performed is to perform all the individual rare coagulation factor activity levels. And by that, we have increased our population of mild factor deficiencies. And I think we should, from the EAHAD, from our working group, I think we will, for the next couple of years, we will increase this knowledge, and we will come up with kind of guidelines and recommendations how to improve our current diagnostics to improve the diagnostic delay. I think that is our responsibility as treating physicians to do in the next couple of years. Yeah.
Yeah, absolutely. Again, it's something that we all need to think about. And again, it doesn't matter how mild the symptoms or the type of the disorder it can be quite alarming and critical when it comes to those situations. Again, I wanted to all of you to call for this is basically a call for action, and invite you to stay involved and continue the discussion. Again, this is a joint webinar of the EAHAD and EAHAD, so we are glad to see patients and healthcare professionals talking about this and recognizing the importance of this. EAHAD will organize in the end of the year the ERIN summit as well, where we will have face-to-face event where we will again tackle those issues, and again we will hopefully again in the future even more bring to even more visibility of the extremely rare bleeding disorders. I wanted to ask Christina, Helen, and Saskia as well if you have some final comments, as I see that there are no questions from the floor. I wanted to again thank you for joining this webinar. Your insight is really invaluable, but I really wanted to give you another chance if you wanted to have a final comment.
I think there might be one question in our chat box, but I think I have to translate the question, or is it? Oh, sorry, it isn't a question.
It's greeting, Andre. So
Oh.
it's the question.
Okay, very good. I couldn't translate it. No, what I want to say is that in the Netherlands we have a national campaign to really increase awareness of heavy menstrual bleeding. And so it's very important for the general practitioners and for the gynecologists to be aware that in the majority of the women, it is a normal symptom, but indeed there are a few undiagnosed patients. So general practitioner and a gynecologist must be aware that these might be carriers of hemophilia or patients, women with a very rare coagulation factor deficiency. So in the Netherlands, we are working on that to increase awareness and to revise our guidelines.
It's a good example to others, I would say.
I think I'll just add a slightly different tone that really it's from like people participating in events like this that kind of bring us all together and kind of give everyone ideas to like kind of take to their own country and kind of spreading awareness and kind of how to respond to kind of the needs of different conditions, and actually to learn about a lot of different conditions as well from each other, and kind of good experiences and learning curves that we've all had. So it was really nice to share.
Yeah, I can only add to that. Yeah, I think it's so important to share, and I mean a lot of people who've been to these talks feel it's repetitive or whatever, but I think in every talk there's a new nuance that we can highlight, like as today, for example, with guidelines on how to speak up for yourself. I think that's really the most important one, if not the only one, because yeah, we've all had our situations where we have not been heard, and I think if my improvement shows anything, then how much it is worth actually to speak for yourself and how important it is, because yeah, I think otherwise we will always be a gray mouse, and now we are more than that, and we are gaining more attention. I think we as a rare bleeding disorders group that's really good to see.
Yeah. And again, that shows the importance of the continuous discussion on this topic, not in breakout groups, not in smaller audience places, but really to talk with the general public, again, general bleeding disorder community, and finally with the general public, because again, it's the only way of increasing awareness and advocating, and finally having better diagnosis and treatment for extremely rare bleeding disorders. I really sincerely want to thank all three of you, Christina, Helen, and Saskia, for taking time to share your insights on this topic. We will try to organize even more webinars such as this one. We will organize, again, as I mentioned, face-to-face event, European Rare and Inhibitor Network Summit by the end of the year, where we will, again, try to bring most of the people with extremely rare bleeding disorders to share their experiences and reconnect and connect among themselves to bring to better visibility of extremely people with extremely rare bleeding disorders. I want to thank EAHAD for co-organizing this webinar with us, and I want to thank all of you in the end of the day for attending this webinar, and I'm really satisfied with the number of you attending. And Jim, as you mentioned as well, it's really nice to see to see so many participants from our group attending the webinar. That means that this topic is important and remains important. I thank you all. I'm looking forward to seeing you soon around. We're finishing with 9 minutes earlier, and I leave you to your evenings. Again, thank you so much, everyone, and I'm looking forward to meeting you on some next occasion.